Thank you so much for that kind introduction. I was happy to see from the slide that I have not changed since the morning. So my bio data stays the same. Thank you. Usually speakers who speak in the afternoon session start with a little joke about how lunch may have put the audience to sleep and that they will try to wake them up. But I think they forget that the speaker has had the same lunch. So let us both try and stay awake over the next about 15 to 17 minutes. You could argue about what is tropical dermatology. Is there an element of othering involved in this term? You never hear of temperate dermatology or Arctic dermatology. Why tropical dermatology? But let's not go into that. I just went ahead and I picked two situations to discuss with you. One is infections and the other is pigmentary disorders. Now, at the simplest level, a condition can be challenging because you don't know the diagnosis. So let me begin with an example of that kind. Here are 4 patients whom we saw at different times and for whom we made different diagnoses, all of them wrong. So I wonder sometimes, I only show the mistakes I make. Sometimes I don't make mistakes also. So this we thought was basal cell carcinoma, this we thought was atopic dermatitis, DLE, acquired ichthyosis. But that was wrong in all the 4 cases because when we took a biopsy in these patients, we saw that the dermis was filled with histiocytes. And you can see that there are some organisms, round organisms within each of these histiocytes. And then they're small, about 2 microns in size. And when you do a PAS stain, you see that each of these has a dot and a halo. So these were all cases of histoplasmosis. So in that sense, this does qualify as a challenge. We are talking about challenging cases, a simple one-step challenge. But recognizing that you've made a mistake and finding the right diagnosis makes a pretty significant difference to the outcome. Now, the next couple of challenges I'm going to show you will be slightly more complex than that. I want to start with histoid leprosy. This is a challenging diagnosis because the clinical presentation is not like classical leprosy at all. Histoid leprosy is a variant of lepromatous leprosy. And in general, when we think of leprosy, this is the picture that comes to our mind, that there is a hypopigmented plaque which shows sensory loss. You might have a thickened nerve. This is at the tuberculoid end of the spectrum. When you go to the lepromatous end of the spectrum, you see a large number of small macules scattered over the entire body surface with only slight sensory loss. These patients may have infiltration of their skin, and that's most prominent around the ears, so you should look at the ear lobes. But histoid leprosy looks quite different. What you see are pretty firm, shiny fibrotic nodules which are skin colored, and they may present on completely normal skin. You might have a single nodule or you might have multiple nodules. And they may be mistaken clinically for fibromas. And if you take a biopsy from this, there is a flattening of the epidermis, a clear Gren zone, but then we have this proliferation occupying the entire dermis. And if you look closely, this is a spindle cell proliferation. So if you clinically thought it was a fibroma and that was your diagnosis, and your pathologist is looking at it quickly, they might think, yes, they were right, this is a spindle cell proliferation. But if you look more closely, you'll see foamy histiocytes, a few of them among the spindle cells. And then if you think of histoid leprosy and do an AFB, this is very strongly positive. So histoid leprosy is a clinical and histopathologically challenging diagnosis. So it's easy to miss it on both sides. So we've gone one step more complex than the first challenge that we saw. Let me take it to another dimension of this presentation. Now, this was a man. Now, because we work in a community and in a hospital which sees a large number of patients with leprosy, we are familiar with the presentation of histoid leprosy, and we do make that diagnosis clinically. So this was a patient who presented with skin-colored nodules on his trunk. In addition, he had a peripheral neuropathy with a bilateral foot drop. He also had diffuse hyperpigmentation, and when he was seen in our department, we made a diagnosis of histoid leprosy, and we were pretty confident about the diagnosis. In fact, we started his anti-leprosy treatment while waiting for the biopsy reports. And this is what the biopsy showed. The epidermis is atrophic. There is a clear Grenz zone, but I am saying that just to tease you. Because if you think of leprosy as a clear Grenz zone, you'll make some mistakes. It's not the Grenz zone that tells you it's leprosy. It's what is beneath the Grenz zone. And what is beneath the Grenz zone, here you can see an aggregate of multiple, can you see there are lumina in all of these structures? Some pretty large, some quite small, and very different from the spindle cell proliferation we saw in histoid leprosy. If you go higher, you can see that these are indeed all of them blood vessels. So we are looking at a vascular lesion. You can see the endothelial cell lining. You can see a lobular collection of vessels here. And at the highest power, you can see that some vessels are invaginating into others in the way that a glomerulus does. So this is actually a glomeruloid hemangioma. So now we have a situation where the clinical diagnosis was histoid leprosy and the biopsy diagnosis is glomeruloid hemangioma. But unlike the situation in histoplasmosis, which we saw earlier, this mismatch is not the end of the story. It's actually just the beginning of how to start thinking about this. Because here we thought, okay, this patient has skin-colored nodules, he has peripheral neuropathy, so he must be having leprosy. But now we know that these papules are not histoid leprosy, but why does he have peripheral neuropathy if he has a glomeruloid hemangioma? And the answer to that is that glomeruloid hemangioma is a marker for Poems syndrome. And so when we investigated the patient further, we found that he had peripheral neuropathy. Obviously, this is what he presented with, so nothing new there. But we also discovered that he had splenomegaly and hepatomegaly when we did radiological investigations. We did not find an endocrinopathy, but a serum electrophoresis revealed a monoclonal gammopathy, and he also already has glomeruloid hemangiomas and also has a diffuse hyperpigmentation, which was unexplained with the histoid leprosy, but which we can now explain with Poems syndrome. So this was a more interesting challenge that I wanted to share with you, and which then ended this person's story, and we could then refer him for treatment. All right. So we finished with infections and things that look like infections. Now I want to talk to you about pigmentary disorders. Again, this is a two-step challenge. This is familiar to people who work in our part of the world. This is a condition that's called lichen planus pigmentosus. You could argue that one problem with this condition, or one challenge, is what do you call it? You know, there are so many different names. Which of these is right? In my department, we call it lichen planus pigmentosus because our professor made this name, lichen planus pigmentosus, Dr. Professor Bhutani, and you always have to be faithful to your teachers. So that's why we call it lichen planus pigmentosus. But if you were somebody who called it ashy dermatosis, I would not have much of a battle or a fight with you. But there was a group of 39 experts from 18 countries which sat down to sort this out and the main focus was the terminology. And they came to the conclusion, and this is a good paper. If you're somebody who's interested in nomenclature of conditions, I suggest you read it. And it also describes what each of these various conditions, lichen planus pigmentosus, erythema dyschromicum perstans, idiopathic eruptive macular pigmentation, Reel's melanosis, ashy dermatosis, where they overlap, what the differences are, and you might find it helpful. But you and I are people who look at patients. So here are two people with varying degrees of dermal pigmentation on the face, relatively mild, but enough to trouble her quite a lot. And if you look closely at this patient, there's a reticulate nature to the pigmentation that she has. And it's my impression that when you have this, the treatment response or the chances of improving are a bit lower than when your pigmentation is diffuse. If you take a biopsy from these patients, the most striking feature under low power is the number of melanophages. In fact, we did a study in my department. We looked at 60 patients with lichen planus pigmentosus, and this was the most common finding. Nearly every patient had it. But this is something that is shared with all post-inflammatory processes. Just having melanophages in the superficial dermis does not help you make a diagnosis. But if you have colloid bodies in addition in the dermis, then you know it's a lichenoid process. But again, you have to be a little lucky to find it. And you have to be really lucky to actually see a active lichenoid damage going on, which we can see here. The basal cells are completely lost. You have necrotic keratinocytes, and you have many melanophages. But I want you to recognize that this is the commonest presentation. We had only 4 patients out of 60 who showed active lichenoid processes when a biopsy of lichen planus pigmentosus was taken. Most of them had only melanophages. So though this is a satisfying picture to look at if you've made a diagnosis of lichen planus pigmentosus, it's rare to see this. The second challenge in lichen planus pigmentosus is therapeutic. How do you get these people better? Patients do improve. So this is somebody, Shraddha, who sent me her pictures. This picture was taken when this terrace was being built in her house. The second picture she sent me was a bit larger, but it shows that the terrace is complete. So it was a few months later, and she was, considerably better. These are pictures that I took of another patient. But look at the timelines. August 2018, she has quite a lot of pigmentation. In August 2022, she's a lot better. So usually, this is, I would say, pretty extreme. Actually, she didn't come back for the last 2 years because of COVID. So maybe she was better earlier, and an earlier picture might have shown it. But the message here is that changes in lichen planus pigmentosus occur over several months. I am not convinced that what we do in those several months makes any difference. I think it's just the fact that time has gone by is what gets people with lichen planus pigmentosus better. And so my treatment, I have gone to meetings where people have stood up and said that they use vitamin A or vitamin A analogs. I went to another meeting where a professor stood up and said he used vitamin C and he got a good results. And being the kind of person I am, I came back and I started using vitamin B. And I find good results with vitamin B. So I don't think it's the vitamins or anything else that are getting patients better. It's just a process that the dermal pigmentation gets removed by the bodies, and so they do recover. But where is the challenge in this? Okay, the challenge is in the name. The challenge is in the histopathology not being lichenoid, and the challenge is in therapy. And I'm going to end with this last challenge that we have when we see patients with diffuse facial pigmentation. Here it's a bit light, but you can see there's this bluish gray pigmentation on the upper lip and the nose and also around the eyes. Do you see that? Dermatologists can see it with ease. But when a biopsy was taken from this patient, this is what it showed under low power. Nothing at all. Not even the melanophages in the upper dermis, which we said is a frequent finding in patients with lichen planus pigmentosus. So let's look at this in higher power. Medium power, still nothing. Even higher power, 40x, well, you begin to see that maybe there's a little bit of action over here. And if we go to the highest power, we now begin to see these black dots in the follicular sheath. And we look around a bit more, and we see them in the vessel wall, and a few in the collagen. And then we look a bit more, and we find another hair follicle with multiple black dots confined to this area, and a few scattered in the surrounding dermal collagen. Okay? So what's the diagnosis? Silver. That's the right diagnosis. This is argyria. So it looked like it was lichen planus pigmentosus, but when you did a biopsy, you found that it was argyria. Historically, this is related to the ingestion of silver-containing medications, which have now been phased out. So why did my patient get argyria? She showed me why. This is betel nut covered with silver foil. This is very easily available. You can eat it. It's pretty tasty. And she brought it and showed me that I was eating 500 grams of this every month for many months. But I think there are many people who eat this betel nut. So there is an element of individual susceptibility to how you process the silver. And some of us probably dump it in our skin, and we get that pigmentation. So that brings me to the end of my presentation. Once again, I will leave you with a visual summary. That's a case of histoplasmosis, where we never made the diagnosis, even though there was a wide range of clinical presentations. That's a case of histoid leprosy, which looks very different from ordinary leprosy. And the biopsy also looks different, so you have to be careful in order to make the diagnosis. This was something that looked like histoid leprosy, but actually turned out to be glomeruloid hemangioma of Poems syndrome, and that explained the peripheral neuropathy that this patient had. This is lichen planus pigmentosus, and this is the cause of my patient's argyria. Thank you very much for your attention.